Welcome to this Adult Health and Medical Surgical NCLEX review. Today we're going to practice thinking like the exam. The NCLEX is built around client needs and clinical judgment, including recognizing cues, analyzing cues, prioritizing, acting, and evaluating. When you read a question, do not jump straight to the answer. First ask, what is the problem? What finding is abnormal? What can kill the client first? Then choose the nursing action that addresses the most urgent risk. Adult med-surg questions are commonly layered. You may see a client with heart failure who is also in diuretics, has abnormal potassium, and is suddenly short of breath. The correct answer is usually the safest first nursing action, not the longest intervention. Prioritization is one of the highest yield NCLEX skills. Start with airway, breathing, and circulation. A client who cannot breathe safely is more urgent than a client with pain or teaching needs. Next, compare stable versus unstable. A new change in level of consciousness, oxygen saturation drop, chest pain, severe bleeding, or absent pulses are urgent. Chronic problems matter, but acute changes usually come first. For example, chronic numbness from neuropathy is important, but sudden unilateral weakness could be a stroke, and it becomes the priority. The muscle hierarchy of needs is helpful, but only after you have ruled out immediate physiological threats. Respiratory questions often test whether you can detect deterioration early. Restlessness and confusion can be early signs of low oxygen. Do not wait for cyanosis because that is late. In COPD, students sometimes think oxygen should be avoided. That is unsafe. Oxygen is given when needed, but it is titrated carefully, and the nurse monitors respiratory status and carbon dioxide retention. For asthma, wheezing is concerning, but a silent chest means almost no air movement. That is an emergency. In pneumonia, think infection plus impaired gas exchange. Interventions include positioning, oxygen is prescribed, coughing and deep breathing, incentive spirometry, hydration if not contraindicated, and timely antibiotics after cultures if ordered. For oxygen devices, know the purpose more than the exact numbers. Nasal cannula is for mouth support. A non-rebreather can deliver high oxygen during acute distress. CPAP and BiPAP help keep alveoli open and support ventilation, but the client must be awake enough to protect the airway. With a tracheostomy, safety equipment at the bedside is essential because accidental decannulation can become life-threatening. Suctioning is not routine every hour just because a trach exists. It is done when there are secretions, coarse sounds, visible mucus, or oxygenation problems. Always assess before and after. Chest pain questions are about time-sensitive recognition. Acute coronary syndrome may look classic, but it may also present as shortness of breath, fatigue, indigestion, or nausea, especially in older adults and clients with diabetes. The nurse should stop activity, assess vital signs and pain, obtain a 12-lead ECG, administer oxygen if hypoxic, and follow orders for aspirin and nitroglycerin. Nitroglycerin can drop blood pressure, so check blood pressure first. It is also contraindicated with recent use of medications for erectile dysfunction because severe hypotension may occur. Persistent or worsening pain is not normal and must be escalated. Heart failure is a fluid and pump problem. Left-sided failure backs up into the lungs, causing crackles, shortness of breath, orthopnea, and in severe cases, pink frothy sputum. Right-sided failure backs up into the body, causing jugular venous distension, peripheral edema, and weight gain. Daily weights are extremely important because weight changes show fluid retention before severe symptoms appear. If the client develops acute pulmonary edema, sit them upright, apply oxygen, assess vital signs and lung sounds, and notify the provider or rapid response while preparing expected medication such as diuretics. ECG questions often ask what to do first. The first step is always to assess the client, not just the monitor. If ventricular tachycardia appears on the monitor, check for a pulse. With a pulse, the client may need synchronized cardioversion or medications depending on stability. Without a pulse, begin CPR right away and defibrillate. Atrial fibrillation increases stroke risk because blood can pool in the atria and form clots. Also learn how to connect ECG findings to electrolytes, especially potassium. High or low potassium can create life-threatening rhythm changes. Shock means cells are not getting enough oxygen and perfusion. Do not wait for severe hypotension because that can be late. A client may first show tachycardia, anxiety, decreased urine output, or skin changes. In sepsis, older adults may present with confusion rather than a high fever. Priority care includes supporting airway and breathing, establishing IV access, drawing cultures if ordered before antibiotics when this does not delay treatment, giving fluids, administering antibiotics promptly, and monitoring urine output and lactate trends. The NCLEX wants you to catch deterioration before collapse. Neurological questions require careful timing. For suspected stroke, the last known well time determines eligibility for time-sensitive therapies. Check glucose, because hypoglycemia can mimic a stroke. A CT scan helps determine whether the stroke is ischemic or hemorrhagic. Before giving food, fluids, or oral medication, the client must pass a swallow screen to prevent aspiration. During a seizure, protect the client from injury. Turn them to the side if possible, time the seizure, and never restrain or put anything in the mouth. For increased ICP, a decreasing level of consciousness is often the earliest and most important sign. Diabetes questions often test the difference between hypoglycemia and hyperglycemic crisis. Hypoglycemia is immediately dangerous because the brain needs glucose. If the client is awake and can swallow, give fast-acting carbohydrate. If unconscious, prepare glucagon or IV dextrose depending on orders and access. DKA includes ketones and acidosis, often with cosmal respiration and fruity breath. HHS causes severe dehydration and neurological changes, usually without significant ketones. In both DKA and HHS, fluids usually come first, then insulin, while monitoring potassium very closely. Renal questions are high risk because kidneys control fluid, electrolytes, and waste removal. In acute kidney injury, urine output may drop and potassium can rise quickly, causing dysrhythmias. In chronic kidney disease, expect anemia because the kidneys produce less erythropoietin and bone issues become of calcium phosphate imbalance. For dialysis access, protect the fistula or graft. Do not take blood pressure, start IVs, or draw blood from that arm. Always assess for Bruin thrill. In older adults, urinary infections may show as confusion, weakness, or false rather than classic burning. Electrolytes are a favorite NCLEX topic because abnormal levels can quickly become fatal. Potassium is the biggest cardiac danger. Hyperkalemia can cause lethal dysrhythmias. Hypokalemia can cause weakness, ileus, and makes digoxin toxicity more likely. Sodium is closely tied to neurologic status. Low sodium can cause confusion and seizures, while high sodium often reflects dehydration and can cause agitation or restlessness. Calcium changes show up in muscles and nerves. Low calcium may cause tingling, tetany, and positive Gvostek or Trousseau signs. GI questions often involve fluid loss and bleeding. In GI bleed, prioritize circulation. Vital signs, mental status, signs of shock, IV access, labs, and possible transfusion as well. With bowel obstruction, do not give oral intake. The bowel needs rest, and an NG tube may be used for decompression. Pancreatitis causes severe pain and inflammation. Care often includes NPO status, IV fluids, and pain control. In cirrhosis, the liver cannot clot well or detoxify ammonia. Watch for confusion from encephalopathy and bleeding from varices. Lactulose helps remove ammonia through stool, so diarrhea-like frequent soft stools may be expected, but dehydration must be monitored. Blood and cancer questions focus on oxygen delivery, infection prevention, and bleeding precautions. Anemia reduces oxygen carrying capacity, so the client may have fatigue, dyspnea, and tachycardia. Neutropenia means the client may not show strong signs of infection. Fever can be the first and only sign, so it is urgent. Thrombocytopenia increases bleeding risk, so avoid IM injections. Use soft toothbrushes, electric razors, and monitor for petechia or blood in urine or stool. With cancer, know the emergencies, such as spinal cord compression, that can cause back pain and weakness, tumor lysis that can cause dangerous electrolyte shifts, and superior vena cava syndrome that can cause facial swelling and breathing problems. Endocrine questions are often about extremes. Thyroid storm is too much thyroid hormone. The body is hypermetabolic with fever, tachycardia, hypertension, and agitation. Myxedema coma is severe hypothyroidism. Everything slows down, including temperature, heart rate, blood pressure, and level of consciousness. Addisonian crisis is adrenal insufficiency and can cause shock, low sodium, high potassium, and hypoglycemia. Long-term corticosteroids suppress the adrenal glands, so they must be tapered and never stop abruptly unless directed by the prescriber. Musculoskeletal questions are not just about bones. They're about complications. Compartment syndrome is a surgical emergency. The key sign is severe pain out of proportion to the injury, especially pain with passive stretch. Do not rely only on absent pulses because that can be late. Fat embolism syndrome can occur after long bone fractures and causes respiratory distress, confusion, and petechia. For immobile clients, prevent pneumonia, pressure injuries, DVTs, and falls. Early mobility and safe transfer are major nursing priorities. Perioperative nursing follows a predictable safety sequence. Before surgery, confirm consent, allergies, NPO status, identity, procedure, and site marking. Consent must be obtained before sedating medications. After surgery, airway and breathing come first because anesthesia can depress respiration. Watch for hemorrhage through vital signs, mental status, skin, and drainage. Atelectasis is common after surgery, especially when clients avoid deep breathing due to pain. Teach splinting, incentive spirometry, coughing, and ambulation. Prevent DVT and pulmonary embolism with movement, compression devices, hydration if allowed, and ordered anticoagulants. Isolation questions are usually straightforward if you connect the organism to the root. Standard precautions apply to everyone. Contact precautions require gown and gloves because the organism spreads by touch. Droplet precautions require a surgical mask because large droplets travel short distances. Airborne precautions require an N95 or respirator and negative pressure rooms because tiny particles remain suspended. C. diff is a special high-yield topic. Alcohol gel is not enough for spores, so use soap and water and appropriate environmental cleaning. Medication questions often ask what assessment is needed before giving the drug. For opioids, respiratory rate and sedation matter more than pain score alone, because respiratory depression can kill. For digoxin, check the apical pulse and potassium, because low potassium increases toxicity risk. For anticoagulants, monitor bleeding, bruising, hemoglobin, and safety. ACE inhibitors can cause cough, high potassium, and rare but serious angioedema. Diuretics require monitoring blood pressure, intake and output, daily weight, and electrolytes. Pain management is both physiological and ethical. The client report is the most important pain indicator unless they cannot communicate. Assess pain fully and reassess after interventions. Giving pain medication before mobility, coughing, or wound care can improve outcomes because the client can participate. Palliative care is not the same as giving up. It focuses on quality of life and symptom management and can occur alongside treatment. Ethical questions often test autonomy, which means respecting the client's informed choices, even if the nurse personally disagrees. Let's review how to attack NCLEX questions. Read them carefully and identify the client, diagnosis, timing, and what the question is asking. Words like first, priority, immediate, best, and most concerning change the answer. Eliminate choices that delay care, ignore safety, or pass the problem to someone else when nursing action is required. Assessment is often first, but not always. If the client is not breathing, you do not assess for 10 more minutes. You need to intervene. For select all that apply question, treat an option as a true or false statement. Do not look for a pattern like 3 answers or 4 answers. Use your own clinical judgment. Now, let's test your knowledge. A client with COPD is admitted with pneumonia. Which finding requires the nurse's immediate action? A. Productive cough with yellow sputum. B. Respiratory rate of 32 per minute with new confusion. C. Temperature of 38.1 Celsius after admission. Or D. Oxygen saturation that is 91% on prescribed oxygen. Correct answer is B. Respiratory rate of 32 per minute with new confusion. New confusion with tachypnea suggests worsening hypoxemia or respiratory failure. Productive sputum and fever are expected with pneumonia. An SpO2 of 91% may need monitoring, but acute mental status change is the most concerning. Question 2. A client reports chest pressure after walking to the bathroom. Which action should the nurse take first? A. Obtain a 12-lead ECG. B. Ask the provider for morphine. C. Stop activity and help the client rest in bed. D. Teach the client about low-fat diet choices. Correct answer is C. Stop activity and help the client rest in bed. The first action is to decrease cardiac workload by stopping activity and placing the client at rest. ECG and medications may follow, but immediate rest is the fastest nursing action. Question 3. A client receiving IV insulin for DKA has a potassium level of 3.1. What is the priority concern? A. Insulin may worsen hypokalemia by shifting potassium into cells. B. The client is developing fluid volume excess. C. The glucose level will increase rapidly. D. Ketones will immediately disappear. Correct answer is A. Insulin may worsen hypokalemia by shifting potassium into cells. Insulin drives potassium into cells, so giving insulin when potassium is already low can cause dangerous hypokalemia and dysrhythmias. Potassium replacement is commonly needed before or during insulin therapy depending on protocol. The nurse is caring for 4 clients. Which client should be seen first? A. Client with chronic kidney disease reporting itching. B. Client 1, day post-op with calf pain and sudden shortness of breath. C. Client with pneumonia requesting cough medication. Or D. Client with diabetes needing discharge teaching. Correct answer is B. Client 1 day post-op with calf pain and sudden shortness of breath. Calf pain plus sudden shortness of breath suggests possible pulmonary embolism, an acute life-threatening complication. The other clients have important needs but are not the priority over a possible pulmonary embolism. A client with a new arteriovenous fistula asks why blood pressure cannot be taken on that arm. What is the best response? A. It could reduce blood flow and damage the axis. B. It will make the blood pressure reading too high. C. It increases the risk for low blood sugar. D. It prevents the dialysis machine from working today. Correct answer is A. It could reduce blood flow and damage the axis. Blood pressure cuffs, venipuncture, and IVs can impair circulation, can cause clotting, or damage the dialysis axis. Protecting the axis preserves future dialysis function. A client with cirrhosis becomes confused and has asterixis. Which medication does the nurse anticipate? A. Lactulose. B. Furosemide only. C. Warfarin. D. Loperamide. And the correct answer is A. Lactulose. Confusion and asterixis suggest hepatic encephalopathy from elevated ammonia. Lactulose helps reduce ammonia through bowel elimination. Loperamide would be inappropriate because it slows stool elimination. A client with a CAS reports severe pain unrelieved by opioids and pain with passive movement of the fingers. What should the nurse do first? A. Elevate the extremity above the heart and reassess in 4 hours. B. Apply ice and document expected post-fracture pain. C. Notify the provider immediately about possible compartment syndrome. D. Remove the cast independently. The correct answer is C. Notify the provider immediately about possible compartment syndrome. Pain out of proportion and pain with passive stress are classic early signs of compartment syndrome. This is an emergency requiring immediate provider notification. The nurse should not delay care or independently remove the cast unless specifically trained or authorized by facility policy in an emergency. Question 8. Which findings in a client with suspected sepsis require urgent follow-up? Select all that apply. A. New confusion. B. Urine outputs of 15 ml per hour. C. Heart rate of 118 per minute. D. Warm, flushed skin with fever. E. Client asks for an extra blanket with stable vital signs. And the correct answers are A, B, C, and D. Sepsis may occur altered mentation, decreased urine output from poor perfusion, tachycardia, and fever with warm flushed skin early. Asking for a blanket alone with stable vital signs is not an urgent sepsis clue. Which instructions are appropriate for a client taking warfarin? Select all that apply. A. Reports black stools or unusual bruising. B. Use a soft toothbrush and electric razor. C. Double the dose if one dose is missed. D. Keep vitamin K intake consistent. E. Take aspirin freely for headaches. And the correct answers are A, B, and D. Warfarin increases bleeding risk, so bleeding signs must be reported and injury prevention is important. Vitamin K intake should be consistent. Clients should not double dose or take aspirin or NSAIDs unless approved because bleeding risks are increased. And for our last question, question 10. The nurse teaches the client after a total hip replacement. Which statement indicates correct understanding? Select all that apply. A. I will avoid crossing my legs. B. I will use a raised toilet seat if instructed. C. I should report sudden chest pain or shortness of breath. D. I can bend deeply at the waist to tie my shoes right away. E. I will follow weight-bearing instructions from my care team. And the correct answers are A, B, C, and E. Hip precautions commonly include avoiding leg crossing and excessive hip flexion using adaptive equipment and following weight-bearing orders. Sudden chest pain or shortness of breath may indicate pulmonary embolism and must be reported. Deep bending can risk dislocation depending on surgical approach and precautions. All right, future nurses, that's it for today's NCLEX review. I hope this video helped you feel more prepared, more confident, and reminded that you are capable of passing this exam. If you found this video helpful, don't forget to like, subscribe, and turn on the notification bell so you don't miss more NCLEX reviews, nursing tips, and exam strategies coming your way. Thanks for watching!